So we are here to talk about why the cost of healthcare is so dang high. And I'm here with three people who really know that from an on-the-ground perspective. So I wanted to start with you, LaShawn. Can you just tell us, as someone who works with people with diabetes day in and day out, what are some of the challenges to affording care when you have type 1 or type 2 diabetes or, a similar chronic disease, we could imagine?
Thank you. So the American Diabetes Association is the largest voluntary health organization that focuses on people with type 1 and type 2 diabetes, so all people impacted by diabetes. Health insurance is critically important to the success of one's management of their disease. Each year we survey the diabetes community, particularly our advocates, to find out what are things that are important to them, and health insurance ranks number one. It's been that way for quite some time, and so one of our key priorities that we focus on at the federal and state level is how do we access affordable and adequate care. A person with diabetes, they often have to see many different providers. They may be on an array of medications, and so accessing the things that they need is very important. We know that it's top of mind when it comes to someone living successfully with diabetes.
What are some of the biggest, is it insulin that's the most costly, or what are some of the things that are most costly specifically?
So there are many different things that go into the management of diabetes. So there are the medications that one may take, the testing devices that they may use, and other services in their management. We do know that insulin is an example of a drug that a lot of people struggle to afford. For someone with type 1 diabetes, for example, it's not an option. They need insulin to live, and so we have been working to address the rising cost of insulin, but there are many different things that go into the management and care of one with diabetes.
And how will some of the changes to Medicaid affect that, like the work requirements and things like that are coming down?
So we have concerns at the association about some of the newer policies that are coming out. So we think it would present a barrier. There are a lot of restrictions and a lot of, there's a lot of effort that the patient has to do in order to comply with this process. We know that there's not strong data supporting that it's a successful policy initiative. So, we have submitted formal comments about our concerns with these type of requirements. What we do know is that for people that were new to Medicaid through the expansion of the Affordable Care Act, that more people were screened, and subsequently we learned that there were more people with diabetes who were undiagnosed, and they were able to have treatment earlier. So we are very supportive of increasing access and making it easy for patients to access the care that they need.
So we all agree health insurance is important, and here I have this very colorful dollar, which is your healthcare dollar. And so, Richard, why don't you tell us a little bit about what this dollar is and what are some of the, I guess, when an insurer gets a dollar from a patient, where does that dollar go?
Thanks, that's a great question, and we just released this yesterday. First, let's talk about where the dollar comes from. It comes from basically two places: employers, or in the case of public programs, it comes from taxpayers. That money comes to the insurer, who does basically two things. One is spreads the risk across the population, and the other is becomes a steward of the resource and tries to be a good steward. So where that money goes, mostly it goes directly as a pass-through to providers and to pharmaceutical costs. This year, the biggest cost was prescription drugs at 23 cents. If you look back at 2007, it was 14 cents. It's now the highest. Last year was the first time it has been the highest. So that price has been going up. The amount of money we pay for prescription drugs goes up every year. And the commissioner said maybe the list price is going up faster than the net. Nonetheless, the biggest part of the dollar is going to prescription drugs right now.
Okay. And what are some of the challenges that insurers have when it comes to bringing down healthcare prices? What happens when you try to get a lower price for a drug, for example?
Well, insurers have a lot of tactics to try to bring down prices, so let me just start there. An important one is just trying to do payment redesign, getting away from this fee-for-service, which provides disincentives to be efficient. Another is to basically keep patients well. We invest a lot in wellness programs. Employers are very interested in keeping their workforce well, so that's another thing we do. And we also negotiate, of course, with providers, with doctors, hospitals, to set a fair price. In terms of drug prices, we do negotiate directly and through PBMs to keep the prices down as best we can. In places where we can't negotiate and have monopoly pricing, that's beyond our control. But I think if you remember, insurers and consumers are really the only people presented with bills. Everyone else in the system is issuing a bill.
Yeah.
So we are on the same side of the line as the consumers when it comes to trying to hold costs down.
Right, right. Well, and I wanted to talk about a different approach to insurance in that case, which maybe you could tell us a little bit about why we need VBID and what VBID is.
Well, thank you. I think it's really interesting as a practicing clinician that we spend so much time talking about money and not about health. And I think my first tweetable soundbite is, we have to change this discussion from how much we spend to how well we spend. Because no one, I think, in the room would disagree that $3.7 trillion, there's enough money there, and we're just not performing in that way. And since I did not go to medical school to learn how to save people money, I went to medical school to learn how to make individuals and populations healthier. I think that as opposed to just looking at that dollar, you look at what you're getting for what you're spending. Right? So I have felt that if you're telling me that we're spending more on drugs and less on hospitalizations, which is exactly the case since 2007, I think that's a good thing. I'd rather give someone a pharmaceutical than visit them in the hospital. So we have been trying to figure out ways to engage patients to behave better and be healthier in the real face of a health insurance system that's making my patients pay more for everything. So it's not that they're making people pay for the things that they shouldn't be doing. In the case of diabetes, my patients are being asked to pay full price in a high deductible health plan for the things I beg them to do. And more importantly, the things that I am benchmarked on. So my patient in a high deductible health plan has to pay full price for her insulin, full price for her eye exam, full price for her foot exam, and full price to go to her lab to get her hemoglobin A1C checked. And if that's not bad enough, since half the people enrolled in high deductible health plans don't have the money to cover their deductibles, my patient gave me permission to tell you that she said, I'll either see you next year or when I'm in the hospital, because she can't afford to do those things. So how about instead of having these blunt instruments like deductibles, we have a benefit design that makes it easy for patients to do the things that will keep them healthy and makes it hard for them to do the things that they shouldn't be doing. And we're lucky enough or unlucky enough to have 30% of our spending go on things that don't make people healthier at all. So I'd much rather have the focus on the $1 trillion of the things we shouldn't be buying as opposed to arguing about a life-saving drug that may be too expensive. I would love to get to that point. So what value-based insurance design does, as opposed to most Americans in the room who pay their cost sharing based on the cost of the service, we set cost sharing based on the value of the service. And for most who haven't heard this before, one of the most popular implementations of the Affordable Care Act that was mentioned earlier is most Americans do not have to pay a penny for 80 evidence-based preventive services. And that is the best implementation of value-based insurance design on the preventive front. So we have a success there. We have not been able to pull it through as well on the chronic disease side. So value-based insurance design, largely driven by the private sector, which said, maybe I should lower my cost of my insulin and my statins and my drugs for HIV, has kind of caught rare bipartisan fire here in this town. We now have a Medicare Advantage demonstration that allows VBID principles in all 50 states starting in 2020. We now have a very strange bedfellow multi-stakeholder coalition to allow high deductible health plans to cover services like insulin on a pre-deductible basis that hopefully will move forward. And I think it's unusual, maybe one of the reasons why I'm here is very few healthcare ideas can get someone from the health plans and the pharmaceutical companies and the PBMs to say, it's probably a good idea to not have my patients have to have a bake sale to afford her insulin or to get a cancer drug that was designed to treat her specific tumor. So we want to reduce cost-related non-adherence, but be fiscally responsible at the same time to make sure that we're not buying the things that we shouldn't be buying.
Well, give us some examples of the things we shouldn't be buying, because I think, you mentioned 3 stakeholders that agree with that, but I also think some patients might you know, whether because they are not informed or because they genuinely think they want those services, they might want, you know, vitamin D testing or something like that.
So we're fortunate enough that the U.S. Preventive Services Task Force, which is an organization that determines those services that are high value, that must be covered full price, they also have a rating called D for services that you should not do at all. So cervical cancer screening under the age of 21. Doing prostate cancer screening over the age of 70. Doing other certain types of diagnostic tests are supported not only by evidence-based groups like the task force, but because of the Choosing Wisely initiative that some people might know, that professional societies themselves are basically saying there are certain things that we shouldn't be doing, like antibiotics for viral infections and other types of things. And if we could just chip away at a small part of this low-value care, we could buy a lot of insulin and eye exams for diabetics.
But are doctors prescribing that stuff, or are patients asking for it?
So that's a really good question, whether it's demand side or supply side driven. I think most of the low-value care is supply side driven. And you know, one of my favorite quotes is, "It's difficult to get a man to understand something if his salary depends on him not understanding it." So if you are fee for service and you're on the fence or not aware of the most latest guideline, you're probably going to do more. And Olga, as you point out, in America, it's in healthcare, more is typically better, and we have to change that idea that sometimes doing things is not helpful to the patient. And we're working very hard across multiple stakeholders to understand that the only way we're going to be able to deliver those evidence-based services that I beg my patients to do is we're going to have to basically start chipping away at the billions of dollars that we're spending, start on the easy ones like vitamin D screening and D-rated services to be able to create this headroom to buy more of these drugs and other services that people cannot currently afford.
Well, I wanted to talk a little bit about prevention. I was wondering what interesting initiatives or policies you guys have seen out there that would allow insurers to pay for things that actually keep people healthy rather than just treat them when they're sick.
So there have been lots of changes to how insurers can pay for things as supplemental benefits, and there are lots of creative things that are being done. Many of our plans are very engaged in diabetes prevention programs. They're out in the community working with community partners like Weight Watchers and YMCA to keep patients who have pre-diabetes from going into diabetes, which is when the money starts adding up. So it's good for patients and it's good for, as Mark says, taking that waste out of the system.
And is that, just so I understand, does that mean like if I have Cigna and I go to Weight Watchers, Cigna would pay for my Weight Watchers
In
meetings,
some cases, and it depends. Some of our plans are actually offering programs right in their community sites. So some of our plans give nutrition classes to the community directly, have Zumba classes and other things to get people moving. So they're doing these types of creative things.
That's interesting. Have you seen anything on the diabetes front?
Oh, absolutely. So I'll just expound a little bit about the National Diabetes Prevention Program. So this is a evidence-based program that the association has supported over a number of years, and we were very excited to see Medicare cover the program starting this year. And one of the things we're doing at the state level is encouraging states to cover it through the Medicaid program. We know, so there are 30 million people with diabetes, but there's 84 million more with pre-diabetes. And I think, you know, in the context of this discussion of the cost of care, we are at the tip of the iceberg as it relates to diabetes. About a month ago, we released our economic cost report that showed diabetes is now the most costly chronic disease. And this is, you know, looking at the 30 million. If there's 84 million that potentially could develop diabetes and there's an evidence-based solution that we could cover that could prevent or delay diabetes, we certainly see that as a priority for prevention in this space.
And what's really interesting about the diabetes prevention program, since this conference is access and affordability, having something being covered didn't mean that it was either accessible or affordable, given that Americans are now being asked to pay so much money out of pocket. So because of the evidence base behind the diabetes prevention program, in most situations it's available to eligible individuals at no cost to them, which you can imagine would lead more people to going into the program than if they had to pay full price for cost sharing to see their clinicians, their lab tests, and other types of things. But to build on Richard's point, supplemental benefits is a term that's often thrown around, but there has been major successes recently in the fact that what used to prevent Medicare to doing really innovative things with something called the uniformity rule, which meant that every Medicare beneficiary had to have the exact same benefit design. And that was a fundamental asset of Medicare when it was passed in 1965. The fact that now, with the MA VBID demo being the first, and now a uniformity rule that was put out just a few months ago to say that Richard's constituency can now create benefits around specific conditions and expand them beyond the typical medical circle to include things like transportation, gym memberships, and now even Meals on Wheels. For those of us who care about socioeconomic determinants and realize that most of the management of chronic diseases like diabetes may fall outside of what is typically viewed as the healthcare system, as a very important step forward.
Yeah. Well, I want to take questions from the audience in a minute, but first I wanted, Richard, to just circle back with you on something, because I often get angry reader emails about the fact that insurance.
So do I, by the way.
Yeah, well, part of the deal, I guess. You know, the fact that insurance rates go up so much, and especially you know, on the individual market, the rates have been going up so much in the past few years, and even after, you know, the change in the administrations. I guess I was wondering what happens on the insurer side when rates go up. What's your perspective on, you know, okay, we have to increase the rates now?
Oh, okay, great question. Let's talk about two things, the rates, and also if I could build on what Mark was saying about out-of-pocket costs. So first of all, what drives rates? Your dollar shows it's all of the cost of the care. When that goes up, then the premiums have to go up, and there are only two things that influence the premium. One, that dollar, the cost of the care, and two, the risk of the population over which we must spread the dollar. So if that population gets sicker because healthier people are leaving for whatever reason, the rates go up because the risk has gone up. If the cost of the underlying care goes up, the rates go up. The profit is 2.3 cents on the dollar, so that's not what's driving it. As far as the out-of-pocket goes, I think Mark's been a pioneer here. We really need to look at these blunt tools like deductibles. We don't ever want things like copays and deductibles to be a barrier to access. It makes no sense to have that barrier placed. So we need to design things more creatively and intelligently. One of the things we do need to think about, though, is there's a misconception, I think, out there that if the out-of-pocket cost goes up, it means the insurer must be paying less and sort of shifting that burden. That's not at all what's happening. I mean, it is true consumers are paying more in general out-of-pocket for things like drugs. However, everybody's paying more. The insurers are paying more. The federal government's costs have gone up 45% in terms of the catastrophic, the drug coverage. And it's true, of course, seniors see more and more of the time they're falling into the catastrophic. But that's easy to understand when prices have risen so quickly and the price of insulin goes from $30 to $330.
Yeah.
So yes, it's true. More people are falling into that and paying more out of pocket. But the government and taxpayers are paying more, and insurers are paying more too. So it's not a cost shift, it's that we're all paying more for these very high prices.
Right.
I just wanted to make that clear.
Yeah. Well, we have time for a few audience questions if you guys have them. And we have mic runners? Do we have mic runners? Yes, someone will come run to you. Right here or wherever you guys are.
Yeah, my name is Jesse Bushman. I work with the Juvenile Diabetes Research Foundation. And just for context, I worked a few years with HHS, and I worked a few years with AHIP, and a few years with a major biopharmaceutical. And what I learned from that is they all complain about each other, and they're all right. But I think in the issue of pricing, where there's been this discussion between the pharmas and the plans, the thing that concerns me is that I think the model there is a little bit upside down with the way the insurance world should work. I purchase insurance so that I can have some stability in my prices, and so that I can be protected from very large build charges, so that the insurer acts on my behalf. And typically they do a good job of that. But I think in the world of pharmaceuticals, it's a little bit upside down. And the reason why is because the list prices that I get exposed to as a beneficiary don't actually reflect the discount that the PBMs and the plans are negotiating. And I'm wondering what you guys think about this idea that's been floated around of maybe having the PBMs get paid simply for administrative services only, that the issue of rebates is taken off the table, so that these incentives for putting high-priced drugs on a formulary, which is also an incentive that drives the manufacturers to have this spiraling increase of cost that does what's happened to insulin. If that was taken away, I think there could be some benefits there. I'm just wondering what you guys think about that.
I think it's worthy of exploration, and I do believe that if that would mean that these prices of the pharma drugs would go down commensurately, that's something that should be explored, because it really, if you think about who benefits from these discounts, why are they there? They're there so that higher priced drugs can find their way into the formulary. I think that's well known. So I do think it's something that should be looked at.
Hi, Carl Schmid with the AIDS Institute. I really appreciate discussion of patient out-of-cost because it's going up, especially with high deductibles and co-insurance. And we're seeing now a practice that some of the plans are instituting and not allowing the coupons, the copay coupons, to help patients get through the deductible and to help them access their drugs, not count towards the deductible and the maximum out-of-pocket cost. I'm trying to understand why this is being implemented, and we just see that as a real access barrier for patients, in addition to the barriers that we already have.
This is a really good question that we've looked at a lot. So I think this kind of ties into another question about this race to the bottom of the various stakeholders. So there are some situations where patients are given assistance programs or copay cards where most of us would agree for services that were not efficient or valuable. We have some PBM experts who would speak to that. The good news is that most of that patient assistance is very, very small relative to the patient assistance that's going on now for these expensive drugs, for the most part, for people who don't want to be on them. They don't want to be on drugs for MS and HIV and diabetes and other types of things. And I think that I've said publicly a number of times, I'd much rather have a manufacturer help pick up an out-of-pocket cost that my patient can't afford than have my patient start a Kickstarter or have a bake sale or other types of things, which is why, again, it depends on what the patient assistance program is for. And we call precision patient assistance in those situations where the drug is clinically indicated, for which there is no alternative, and the patient can't afford it. And we would not like to see continued patient assistance for a drug that has a generic equivalent. And the good news is the stakeholders involved are coming together around this idea to understand that we should allow patients to be able to get some help to afford the drugs they absolutely need, but at the same time, along the high and low value care thing, get rid of those egregious practices that most of us would deem to be just contributing to those higher prices. So patient assistance programs like value-based insurance design depends on the service, who's getting it, and when in the course of the disease. So we want to make sure that in that clinically indicated situation, that somehow the patient is able to get it without having to foreclose on their home.
I think it's a very interesting question, and if you want to talk about coupons, that in the setting of a monopoly, that's one thing. So you're granted a monopoly through the patent system, and rightly so, to return your investment, that's fine. And then you also can print coupons, which is now allowing you to become a discriminating monopolist, which we can take that economic argument and talk about it. But if that's the practice, that's fine. What we're seeing now is this war between, which puts the consumer in the middle with, plans are saying, well, this shouldn't count towards the deductible. In other words, you're asking the plan to sort of chip in money to the coupon. And then the coupon issuer is saying, well, if you don't do that, we won't issue the coupon. So, I mean, what is the purpose of that coupon? Is it to help the patient, or is it, a marketing tactic? And it's unfortunate that the consumer is in the middle of it.
Yeah, I think that might be our time, but thank you so much, Richard, Mark, and LaShawn, for being here today. And thank you, guys.